Thank you, Mateo. I appreciate it. So interesting story. Yeah, seems like I've been everywhere in the world, right? I lost my British accent. I don't think I actually even had one when we kind of migrated to Canada when I was 4. I was speech delayed, so I'm pretty sure I didn't have one. The flight incident, I was watching a movie on that little plane kind of computer screen they give you in front of you, and there's all this commotion. I had a headset on. I'm like, what is going on? And so the lady kind of kept budging me, and I was like, oh, she's being kind of rude. And so I was just waiting for my sandwich. Eventually, she just ripped off my headset. She's like, they're looking for a doctor on the airplane. I'm like, well, I'm just a medical student. I'm not a doctor. And she goes, well, they're the best. They only have you, so you have to go. And so next thing I knew, a stewardess, the whole plane came up to me, and they asked me a few questions, and I'm like, They're like, we need you up front. I was like, okay. So anyways, they took me up to the front of the airplane. They shut all the curtains in first class. I was like, what have I got myself into? Because I really wasn't trained for this. And so it was a pregnant lady, and she's like, I think I'm going to give labor. I was like, I'm kind of interested in psychiatry. Did I tell you? So it was she wasn't really truly going to labor. They got off a cruise ship, so I figured she contracted the Norway virus, something you contract on like cruise ships, and you get like vomiting and all these symptoms. So they didn't have to land the plane, so it saves the flight airlines lots of money if they don't have to land their airplane off route. So that's the story. It was kind of cool. I think I got like a couple $100 from it in Canadian, which is like $2 American. So perspective, right? Okay, so I did this presentation a while ago, but I updated it. I've been tracking substance use in youth for a while, started residency. So when I shifted from Louisiana to Texas to New Mexico over the past years, so I was able to follow the trends. So enjoy your lunch, grab some. I don't think it's rude if you eat. I think it's appropriately fine. So I'm Dr. Sangra. I'm a child adolescent psychiatrist at Peak. Peak Behavioral Health. I'm so blessed and honored to work there. I think we work with a great team of staff, and everyone's committed that works here, like the CEO, our marketing, our therapists, or other physicians, and I think if we're all in this field, I think we're all kind of the same mentality. We're all compassionate about what we do, so I don't need to speak to the choir. So I applaud you guys for the field that you guys are in and all the work that you do. And I'm glad we're not wearing a mask, at least me for now. Okay, so again, this is just, I got nothing to disclose. I'm not making any money from this presentation, although I'm a full-time employee with Peak Behavioral Health. There's no conflict of interest. So these are the objectives. I'm going to look at like trends among youth, local drug use. That'll be kind of like your appetizer. Review pharmacokinetics is kind of like your salad. No one really likes it, but you got to eat it. Recognizing symptoms and dangers is kind of like the meal, and then the treatment options will be the dessert, okay? And that's what I'm kind of excited about. So there's a lot of slides. I'll take you through it. So when I started looking at this in 2003, 2013, there are some trends. The trends at that time, we were seeing a decline in alcohol use and a decline in nicotine, but we're seeing an increase in marijuana at that time. So we're pretty excited. We're like, okay, well, we can handle this. So at least there's a decline in alcohol and nicotine. So over the past years, this is a slide from NHI. This doesn't include the alcohol. This just talks about illicit drugs, which is in kind of like the teal blue color. And then the red is kind of the prescribed medication. So the trends are the illicit drugs. Marijuana is the highest. That's obviously, right? You can see that. The other ones, so the prescribed drugs, the Adderalls, they said Vicodin, which is second, but that's kind of decreasing since there's limited supply on opioids, right? But the Adderalls are kind of misabused and misused, so that's what they mean by that, okay? So again, alcohol is not up there for this one. Okay. Before I start some of these slides, I got kind of overexcited in updating them, and I broke rule number 1 for presentation, like don't put too much verbiage up there, okay? So not too many words. So some of them I've kind of broke the rules, but I'm gonna be really brief about it, okay? So this is the stuff that was done previously by me in a couple presentations, and I kind of crammed it into one slide. And the next slides will show you the trends of most recent. So in 2016, 9% of 8th graders reported marijuana use in the past year and 5% in the past month. Among 10th graders, 24% had marijuana use in the past year and 14% in the past month. Among 12th graders were the highest, and they were at 36% during the prior year. 23% used in the past month. And this is where 12th through 8th graders, 6% said they'd use marijuana daily or nearly every day. Okay. So what changed? I know we had COVID hit, right? So what we anticipated, kind of what happened. We thought we'd see a slow decrease of marijuana use because the pressures were less, and that would continue on. But what they found was and I'll just tell you about it. They did a study again, right? So between the first few months of COVID, they found the overall use of drugs to be a little bit more stable and a little bit less in the first months of the pandemic. But right after that, they actually saw an increase of after 6 months. So that kind of deflected kind of what they were thinking. So adolescents who experienced pandemic-related severe stress, depression, or anxieties, or whose families experienced hardship during the pandemic were most likely to use substances. And I classified them, I think I did it was like a national radio station prior to the pandemic, and we classified them as a fragile family. So families susceptible to like stress, mental, pre-existing substance abuse were kind of a fragile system anyways. So, and that's what they found. They found that those kids out of that system in that family actually experienced higher levels of substance abuse. Okay, so this is from NIH, just some marijuana statistics. So I'm gonna go from like different drugs and substance abuses, but my focus will be actually on marijuana, okay? And this is what they said. They said the NIDA suggested about 9% of people who abuse marijuana will develop an addiction to drug in time, okay? So then they call that substance abuse in adults. What that matters is that you can reduce substance abuse in adults by talking to the kids early. And the reduction is about 50%, that's what they said. So however, that risk does include to that risk does rise to 70% if the users start using marijuana as a habit in their teen years, okay? And so if they actually start using, that risk increases to 17%. Some of them say 7% times higher, and this one says 17%. If they become a regular user, that risk increases to 25 to 50% of carrying that forward to using substances. Okay, lots of words here, but I'm gonna take you through this one too. So I don't know if you guys watch the news and all this stuff, but this was, I was doing this presentation, these things just started popping up in the news. So they found that the college students actually have increased right now. So continued increase over the past 5 years for college students, reaching the highest level in 3.5 decades in 2020. So among the college students, 44% used in the past year in 2020, compared to 38% in 2015. And they say that it's going to continue to rise and it'll probably reach about 50%. And then the next slide say that if you're not in college and you're working, you're actually going to use less. So yeah, if they're going to college, they're prepared that they're going to be using more, okay? And I got different hypotheses on that. But so in contrast to the 12th graders in the recent years, with 35% high school seniors in the past year 2020. Okay. Okay, so just going to talk about alcohol shortly, but I'm going to come back to marijuana, okay? Alcohol is a big problem in El Paso still for teens. We do service that population as well in Texas just because we're kind of a border hospital, but most of our kids do come from New Mexico. And I assume that we have the same issues here with kids as well too. So 28% of the 9th graders drank within 30 days, 18.1% binge drinking, which binge drinking accounts for 5 drinks or more and sitting in one setting. Greater than 50% teens rode with someone that was already drinking. 25% of teens drank and drove. Okay, so just a little bit higher than the national rate. El Paso at 18.1%, which the national rate is 15.3. The next slide, I'm going to just show you about the trends. So remember, in 2013, we were thinking these trends were going to go down. But what happened is there's 2 columns. One looks like a cigarette. That's actually for nicotine use, right? And the other one is a vape pen. And so they have 8th graders, 10th graders, and 12th graders. Consistently in all those grades, you see the vapes a lot higher, okay? And that's what we saw, the introduction of e-cigarettes. So we saw the e-cigarette introduction and the vaping kind of going up and consistently going up through the grades. The other thing, a lot of these kids, 62% of them thought they were getting flavored. 24% thought there might be nicotine in there, and there's a bunch of them that didn't know. And some of them had, about 7% said they had marijuana in there. So teen e-cigarette users are more likely to start smoking within 6 months if they use e-cigarettes. So it's 30% versus 8%. The teens that actually had e-cigarettes, 66% of them actually had kind of nicotine flavor in it, right? So you can buy like these Juuls and all these cartridges, and they have like all these different flavors in them. And it's kind of like, if you're a user, it's a good thing, but if you're a kid and you sell it to these kids, well, obviously they're gonna want the flavors. So it kind of is leading us down kind of a dark hole. So again, 6% marijuana in their e-cigarettes, 13% nicotine, 13%, hey, I don't know, I just got it from a friend. Okay, so what's the college vaping trends? Okay, so I wanted to look at nicotine and marijuana, okay? So vaping, marijuana, and nicotine, 2020s suggested dramatically increases in vaping and marijuana and vaping nicotine among college adults observed between 2017 and 2019. College-age adults who reported vaping marijuana in the last 30 days more than doubled, from 5% to 14%. Again, that's almost the same as kids that didn't go to college at 8% to 17%. In 2020, these increased leveled off with 12% of college students and 14% of non-college respondents reporting vaping marijuana in the past 30 days. So non-significant changing for vaping nicotine at 19% of college students and 24% non-college respondents reporting vaping nicotine in the past 30 days compared to 22% and 18% in 2019 and 6 and 8% in 2017. Again, a lot. So I'm going to just summarize these in a couple words. In alcohol, they saw a consistency of drinking for kids that were going to college. However, they saw a reduction in binge drinking during the pandemic in 2020. And the numbers are higher for individuals that are going to college. So not only will they be more high, they'll be drinking more. So they'll be high and drunk a lot more than if they were just working, okay? And that kind of makes sense. If you're responsible, you go into a job, they're not gonna have you around if you're drinking and getting drunk and using marijuana, right? But the benefit of the COVID was that there was less reduction in binge drinking during the time. So they didn't binge drink, okay? And there's definitely a whole bunch of comorbidities associated with drinking. Some of the other substance they saw a decline of amphetamine and prescription medication abuse in 2020 went down to 6.5%. Cigarette smoking continued to decline in the past 4 years, and it's at its all-time lows at 4%. However, there's still an incline of e-cigarettes. Prescription opioid misuse declined in the past 5 years and is down to 1%. Interesting enough, I don't know if you guys heard of this. I heard one teen that I was treating, and she said that she did a wet line, and I didn't know what that was. And apparently what that was is kind of an opioids mixed in a solution, and she just injected it without the needle, but just injected it through the nostril. Of course, she's a polysubstance user, and this was not her first rodeo, so she was a hard user by that time too. In fact, we found her in a trap house. Okay, so this was another study. This is kind of pretty similar to the kids that we see in our hospital. This was a study in 2017, primarily the blue that makes up the pies. The drug of choice is marijuana, okay? And then the next one, the legal status during these admissions, where they're on some kind of probation, but not related to like a DWI and stuff like that, right? So they have some kind of legal status. That was in this one study. So gender specifically, so the boys, earlier substance abuse than the girls. So the boys were actually used earlier than the girls, but the girls have higher rates of abuse as older adolescents. So they actually use a little bit more than the boys. One study said divided it from males 6.8% and females to 6.4% marijuana use, so kind of even, and then boys more preference for alcohol. Of course, if there's trauma and substance abuse, the substance abuse is going to be 40 to 80%, a little higher. And there's higher rates among the LGBT plus community. Okay, and then there's some studies that did some PET scans. Sorry, on my head. Okay, so, hold on. Yeah, so I wanted to look at some studies that did PET scans. And PET scans are where they kind of inject you with a radioactive dye, and they look at kind of what brain is signaling and stimulated and understimulated. And they kind of gets us to understand like kind of more of the brain and the pathophysiology. So they found that men smoke more often for the rewarding effects of the nicotine in this one study. And women smoke more often to cope with the stress or otherwise improve their mood. So what that showed was that women tend to smoke more kind of for habitual stress, anxiety reasons, whereas men are kind of more driven by that dopamine response. And that's what's going to show you in the next few slides. So men smoke cigarettes, dopamine gets released from the ventral striatum, which is associated with the reward and reinforcement. Okay. For women, dopamine tends to collect in the dorsal striatum, which is more associated with the habitual and learned behaviors, and then those response to negative mood. And that's, of course, it's all rewarded by the same neurochemistry, which is dopamine. And then, so this is kind of like where all those like inner layers go, but these projections go up to the prefrontal cortex, where if there's depletion in that, then you kind of get depression, anxiety. So depression, anxiety kind of hits over here. Oh, sorry. I'm trying to circle with my little circle there, but you guys aren't seeing it on the screen. So in that blue region, that's kind of where depression, anxiety hits. Kind of the inner brain is kind of where all that dopaminergic kind of emotional response goes. And of course, you have projections going out. Okay, so then just a little bit more about the LGBTQ community. So once again, they start a little earlier and they use a little bit longer, okay? So this is what this one is showing you, all this slide. So the LGBTQ community plus is like that peach color. So the top one is what age did you start first? So you can see like 12 and younger, 14 to 17 youngers, they used earlier, okay? And that's going to be pretty significant with the changes that occur later in terms of their brain. Approximately how long did you use for? 6 to more years? That's a lot longer, or larger population at 47%. Okay. And what was the first illicit drug they used? Most of them chose marijuana, okay? So it says that LGBTQ plus individuals have tried 23% more types of drugs than the heterosexual community, okay? So some of the other kind of quick points: tobacco, e-cigarettes products are increasing, smoking overall is decreasing, the use of e-cigarettes for marijuana consumption is increasing. In fact, you can hide the marijuana in e-cigarettes and still use them in classrooms. So, and COVID has had an impact on it. Okay, another nice slide, just a quick point. I like it, it's kind of simple, but then I'll get into the nitty gritty. So marijuana in your kid's brain, less control emotions, worse problem solving, slower processing speeds, lower verbal comprehension, and poor memory. Okay, don't get too entirely freaked out with the slide as well. So I get a question a lot. A lot is like, well, marijuana is good because I guess God created us with receptors and it's a natural plant. Well, actually, we're created with an endocannabinoid system, and that's where the receptors are hitting. And there's cannabinoid 1 and cannabinoid 2 receptors. So the marijuana is actually kind of fitting somewhat like a lock and key in these receptors, and it's working, okay? So it's kind of like having like, I don't know, a fake key and it just happens to work. I don't know if that still happens, but. So the CB1, cannabinoid receptors, right? That's where the THC is gonna hit. I'm getting a little ahead of myself, but that's okay. The THC is a psychoactive ingredient that's gonna create that high, that's gonna actually impact the brain, the neurology. And that sits in the brain, the spinal cord, nerve, and adipose tissue, okay? Adipose is kind of like meaning the fat tissue. And of course, the brain is composed of fat as well. And so it sits in those tissues. CB2 is located in the organs and primarily in the immune system, the brain microglia. I won't get into this, it just kind of gets to neurological. But again, just the frontal part of the brain, and you got a little bit of the inner brain that controls the emotions, the response, some of the reward, and then you get the back of the brain. So this kind of summarizes it as well too. So concentrations of cannabinoid receptors, right? So the cerebellum, that's kind of the back of the brain that kind of coordinates for balance and movement. That's going to be implicated with the THC marijuana use as well. You got the basal ganglia, which will involve the movement disorders. And I'll show you that there's movement disorders as well. The cerebral cortex, and that's kind of a little bit higher up. That's actually where the higher cognitive functioning, drive is. The hypothalamus, which is kind of a little more inner, will impact the appetite. The hippocampus, which is involved in learning, memory, and stress response, that'll be impacted too. And of course, the spinal cord, and they'll use this one for cancer patients. You can give them like marijuana medication, not marijuana medication, but the active ingredient that would reduce the pain receptors in that. So again, Canada, they jumped on the legalization a long time ago. so I was really intrigued by that, just kind of seeing that response. So the cannabis plant actually has like 100 unique compounds. Delta-9 tetrahydrocannabinol. THC is the active cycle compound, which we already kind of know, right? There's some, the CBD is the receptor that it sits on. The THC concentration measures the cannabis potency. So the way they do it is they do a ratio. The ratio is THC over CBD. Okay, so then you guys seen the CBD oils around, right? You guys have all seen that, right? Okay, so that's the other component other than the THC, right? So they spread it up in a ratio. And it's really hard to get 100% CBD and no THC. It's very Like it's impossible. Like it's really hard. So the ratio of THC over CBD has gone up significantly. It used to be in the 60s, like 1%, but in the 2018s, we were seeing it at 30 to 1,000%. And so that potency is what actually gives you that high dopaminergic rise, right? Because it's that much stronger. So there's different types of plants, right? Sativa, indica, hybrid, and then you can have the waxes and the cartridges and the dabs and stuff. And that's all that stuff I kind of incorporate into my Psych Eval, which I'll talk about as well too. So let's talk about the reward response. Just remember, this is the salad. It's kind of like it's there, but you have to talk about it. It's kind of, you don't enjoy it, but let's just talk about it. I like talking about it. So okay, THC activates the cannabinoid receptor 1, right? Which is a dopaminergic mesolimbic brain circuit, and increase the presynaptic dopamine, and which results in increased dopamine. So what that's all saying is a whole bunch of mumbo jumbo. Is that the brain region where the reward response is actually started, is that the marijuana hits that receptor, and those presynaptic vessels, dopamine is actually stored there. So it can't be just built up and made and then transplanted. You can actually have stored vessels of that. So it's kind of like, you guys remember the pandemic? I mean, we still do, right? The toilet paper or paper towels, right? It's whatever Walmart has in the back, right? So it's the same system. You go to get some paper towels. Well, what do they have in the back? Well, that's presynaptic, right? So if they bring it out to the front, well, now it's actually increased. It's released. But if they don't have any stores of any dopamine, they don't have any paper towels, well, they can't give you any, right? That's all that means, okay? Does that kind of make sense? I thought of that last night. I was like, that's kind of a cool analogy. I was talking to myself, but I mean, my own brain said it was a good idea. Okay, so chronic use, right? So, okay, if they use more than weekly, it's just described as chronic use. And what that happens, it downregulates the brain's receptors. And what that means, it starts turning off some of those receptors, and you can't actually get to that. And I'll explain why during the pharmacokinetics. But it takes several days for up to kind of reintroduce those receptors again. So what that means is you got that increased tolerance rate. So these kids, when they use the marijuana, they need to use more of it to get that kind of initial drive. So we get a lower high, and they're always trying to chase the first high, right? Sounds like addiction, right? So, and that's what it is, right? Okay, pharmacokinetics, bear with me. Okay, so smoked inhaled THC, right? Systemic bioavailability of THC is 15 to 30%. What that means is 15 to 30% actually enters your bloodstream. And because it's inhaled, it kind of goes directly into your bloodstream through your lungs, okay? The peak effect is 15 to 30 minutes, lasting to 1 to 4 hours. Another study said that the dopamine response was actually before you actually smoked it. So they're actually anticipating smoking the marijuana, and the dopamine increases right away. And that's kind of like the addiction, Okay, so edible marijuana, right? The bioavailability is a little bit lower. So in other words, only 5 to 10% get into the bloodstream because it has to get bypassed through the liver. The liver doesn't want this stuff in there, so it kind of like takes it out, okay? And then, so absorbed from the blood into the fat. So that's where the marijuana can sit, the THC. It can sit in the brain, it can sit in the body, and it sits in the adipose tissue. So it sits there, and it can sit up there for 8 weeks. So the THC is released when it's low in the body because it's sitting in the adipose. So another study actually monitored the marijuana within the bloodstream, and they found out that even when the child wasn't smoking, there's still a little bit in the system because the body itself was allowing it to escape from the adipose tissue back into the blood for actually to continue to have a little bit in that system. Almost like homeostasis, right? For pregnant women, it crosses the placenta, can accumulate in the breast milk for up to 8 times as great. It's metabolized in the hepatic cytochrome enzymes, which is 450 and 2C9. So there's certain medications that are metabolized through those cytochrome, liver enzymes and stuff. So marijuana is competing against that same enzyme that's metabolizing that medication, so it can impact different concentrations of medications as well too. So, and a lot of stuff goes through that P450. So delta-9 tetrahydrocannabinoid THC binds to G protein and is a partial agonist. And I'll explain to you in a slide why that's important. And G protein means that there's already, it's a receptor that's in the brain, and it has to go through certain signaling to activate that. Okay. So you have full agonist, which is like more the synthetics, and then you have partial agonist, which is THC. So let me tell you, in the next slide, I'll explain a little bit more. Let me tell you about synthetic cannabinoids, and then I'll tell you more about the partial agonist. So synthetic cannabinoids, I haven't seen as much as here as I did in Louisiana. It was just, it seems like everyone was doing spice. And it was, like when you first see, they're so aggressive, you don't know what's going on. They're so psychotic. And so spiced K2, has anyone seen anyone use it here? Or any kids, or you have? Okay. Okay, so they don't have the same chemical structure. And it's not detected on urine drug screens. It's about 800 compounds. High school students at that time in 2015, when it was Louisiana, was what, 2.9%. It's a pure agonist. What means it's got very high affinity for that receptor. It'll go in, sit on it, and it will turn it on to 100%. But then because it's a pure agonist, it kind of like gets off of that receptor as soon as it's done activating it. Okay, and that's going to be important. I'll tell you why in the next slide. Cannabis contains compounds that counteract its effects of THC. Synthetic compounds don't. So they found some compounds with the real cannabis that actually counteract that full agonist. And what that means is it becomes a partial agonist. So this is like pharmacy, okay? So the first slide, first kind of downhill slide there is a full agonist. So that's kind of like the synthetic cannabinoid, right? The synthetic K2 spice. When it sits on that receptor, you have like 100% of the activation of that receptor. But as soon as it leaves, it turns off and it goes away. However, the cannabis, THC, is a partial agonist. What that means, it sits on that receptor a little bit longer. It doesn't turn it on at 100%, but still turns it on, but it sits on it. It sits on it and then it locks it, and it doesn't get off that receptor. So when it locks it, the receptors deregulate. So they deregulate, they go down, and your brain has to make up more receptors to get that first high. You see, so the receptors go down, and then the brain automatically starts making up that CBD1 receptor. Okay, so one of the things when I deal with a kid that's at peak, and we shared about the marijuana use and their drugs use, I kind of want to look at the withdrawals. I kind of let them know there is withdrawals for marijuana, usually last 2 to 4 days, and this is what we're going to go through. And I offer them advice. So like, hey, I can monitor the withdrawals and treat you for the withdrawals, or you can wait and we'll treat you post-withdrawal. Most want to just wait till post-withdrawal, but some of them actually want to be treated for it. So common symptoms of withdrawal are irritability, anger, anxiety, depression, restlessness, sleep difficulty, insomnia, vivid dreams, decreased and increased weight, abdominal pain, shakiness, tremors, sweating, fever, chills, and headaches. Of course, sleep is affected, different stages of sleep. So increased sleep latency, it takes longer to get to sleep. Total sleep time is decreased. Decreased sleep wave. Slow wave sleep is what you need to have a restful sleep. So it's decreased of that. The whole efficiency of sleep is decreased, and you have changes in the REM cycle as well. So synthetic cannabinoids, withdrawal symptoms are like opioid and alcohol withdrawals. You have a little bit more serious withdrawals. You have like tachycardia, Q2C prolongation, could be life-threatening. You got hypertension, diaphoresis, kidney failure, seizures, and psychosis and delirium. So it's kind of a different withdrawal than the cannabis. So these synthetic. The intoxication, inhaled doses of 2 to 3 milligrams of delta-9 THC impair attention, concentration, short-term memory, executive functioning. More severe adverse effects may occur at doses at 7.5, including nausea, postural hypertension, delirium, panic attacks, anxiety, and myoclonic jerking. Psychosis has also been associated with the use of higher potency concentrated marijuana products. And that becomes important because when I'm talking with the teen and they're telling me they're doing dabs and wax, and I know that's a higher potency concentration drug, I'm going to look out for that. And usually the first psychotic symptom I see with any kid or person using marijuana is paranoia. I'll see the paranoia before anything. And so if I read that on a chart, I read paranoia, and I read that there actually has some substance abuse like marijuana, I'll start thinking, I'll start questioning about like how much they're using, what do they use, I'll get right into that. Because I want to be able to kind of monitor their psychosis and actually treat it. Some of the other things that we have to watch out for intoxication is tachycardia, increased blood pressure, especially for the elderly, orthostatic hypotension, increased respiratory rate, congenital injection, red eye, dry mouth, increased appetite, nystagmus, ataxia, slurred speech. Some studies I haven't seen this as much, but some studies have said that there's been acute aspirations of and poor asthma response, mediastinum and pneumothorax, so like lung problems like that can kill you. Rarely angina, myocardial infarction. Risk for myocardial infarction among regular use cannabis uses have been found to be as high as 4.8% times the baseline. Another study I read just yesterday, they said it was close to double, but it was the ages between 18 to 40, which is really rare to have heart attacks there. And the normal range of no one having heart attacks was 0.8%, but it was double that. So it can occur. Okay, so what happens? They ingest the marijuana, they feel high, euphoric, pleasurable feeling, decreased anxiety, alertness, depression, and tension. So one of these questions I'll get to later is I'll ask the child or the kid, I was like, hey, it sounds like you're using all this stuff. What are you using it for? So kind of a non-judgment way to see what they're using it for. And most of them say, well, hey, yeah, I'm using it for anxiety, or I'm using it. So they'll tell me what they're using it for. So I'll know exactly what to treat, okay? So sometimes you can have perceptual changes, colors more brighter, music more vivid, time distortion, perceived time is faster than the clock. So they actually feel like they're accomplishing a lot when they're actually high, but they actually haven't. And spatial perception distortions, mystical thinking, increased self-conscious and depersonalization. High doses of potent THC can create hallucination. With a coordination motor response, you have slow reaction time, impaired attention, impairs concentration, short-term memory problems, and risk assessments. Risk assessments according to like their situation. Like they won't be able to process that they might be in danger, and they find themselves in a lot of trouble. There's a cumulative effect with the other CNS depressant. In other words, so if they're ingesting alcohol at the same time, you can have slower processing speed. You can have more problems with motor coordination as well. Acute intoxication impairs motor coordination and interferes with the ability to complete complex tasks that require divided attention, such as driving. So psychomotor impairment can last 12 to 24 hours. A meta-analysis showed that THC associated with motor vehicle accidents and death and injury is 2 to 7 times higher to get into car accident, with the probability increasing with the THC levels. This is another next slide I thought was really nice, but it's a lot. It's kind of more of a picture for all those enthusiasts who like to figure out where the brain it's attacking and what it's doing. And if I know you guys can't read in the back, which is it's just fine, but one of the things I use with some of the boys is that, you know, it does attack the hypothalamus and you have decreased sexual response because all boys are concerned about that. They don't want to have decreased sexual response. And then, let me go to the next one. Okay, some of the other studies that show that they're less likely to graduate high school, more car accidents, injury deaths, memory, cognition difficulties. They have impulse control, focusing, organization, which is all part of that prefrontal cortex being affected and damaged. So genetic risk, single nucleotide polymorphism. In other words, you can have like some changes in the brain which affect them genetically. You can have psychosis. You can have a decrease of IQ. So IQ is something is what you're born with. You can't get rid of IQ. But marijuana is the only drug that we know that actually decreases IQ. So it actually goes in and actually destroys the brain architecture where your IQ actually drops. And you need IQ, a higher IQ to do stuff like this, right? I tell that to kids, but most of them don't care about that. Because, I mean, that's so long from now, right? Like, oh, why do I need IQ now? I don't need IQ. So you get structural brain changes, primarily in the hippocampus, amygdala, and that prefrontal region. So structural changes, prefrontal cortex, the parietal lobe they showed in PET studies, pruning is affected. I don't know if you guys know anything about pruning. Have you guys heard about pruning? Yeah, you have. Okay, one in the back. Okay, so pruning is, I was thinking about an analogy. Let's say pruning is like road construction, right? You're driving to work and you got road construction, pylons everywhere. You got to go take the back road because you can't get to where you get to really fast. So pruning is getting the roads fixed, taking the pylons out, and you get there faster, right? That's pruning. So the brain actually does that as you're a child, and it continues to do that until you're a little bit older in your 20s, and sometimes 30s. And that's what's affected in autism, is that pruning is affected and they can't have that processing speed. So same things affected in marijuana use, is that pruning is affected. So they got to use these back roads in their brain to get to where they want to get to. So the brain actually has lower blood flow, and it recruits the other brains to other parts of the brain to help get that response. So instead of like going from A to B, it's going to use A to D to F to help out with G to get to B. Does that make sense? So then you get decreased processing speed. And that just kind of helps you explain like what's actually going on. You have damage to the corpus callosum. Corpus callosum is kind of like what attaches your left side to the right side of the brain. Important, I would assume, right? Another nice little slide. There's fun little facts you can give these kids. Here's one from the NIH. It says everything almost what I've said, but just in kind of nice language for the kids to read and stuff like that. But what's affected the kids, the studies have said a lot of the kids stop smoking, not because everything I've told you. They actually stop smoking because their peers see how intoxicated they are and they don't like it. So they start losing their friends. They start losing their social network. And they're like, where is everybody? It's because they've been doing that for such a long time and their progression has just increasingly progressed and progressed and progressed. And relationships health. I talk about kids about their relationships, if they're dating, if their boyfriend or girlfriend doesn't like it, that I use that for the advantage to help them get off of it. So during the time that they're actually on our unit, I got them withdrawal. We're taking care of that. Now we're actually treating them for the anxiety, depression, psychosis, whatever it is. I'll ask if they like that kind of sobriety. Do they like it? Do they? What troubles are they having? And then I'll talk about relationships and the family would be happier of you being like this and maybe treating yourself. medically, appropriately, rather than treating yourself through drugs in your way, okay? So I still think that they're treating themselves, but they're self-medicating. So I use, however, they're self-medicating to help me encourage them to kind of be sober. Of course, we know this is all related to depression. And the severity of depression is higher than not severe. That's what that shows. Since 2004, 2017, depression continues to rise. And something on the news, I think just the other day, they said the teen suicides have increased as well too, up to 50%. So we're seeing that too. And then suicide as well, one of the risk assessments for suicide, it's increased even more exponentially if they're actually using substances, okay? So you're actually, when you're talking about substance abuse, you're preventing one portion of that suicide treatment. Like you're preventing them from hurting themselves, because if they're using drugs and on alcohol, the suicide rates go a little bit higher. That's what this side shows, so we'll skip this one. I'm going to skip the next slide too, if that's okay. Okay, this is the dessert. This is what I like. So Psych Eval is kind of, there's a few questions I picked out. It's like, hey, when did you start? Like, when did you start using this? The average age for marijuana use is 13 to 14. We're starting to see some kids use it a little bit younger, this is 12. Remember, the younger they use it, the worse their prognosis is in terms of substance abuse as adult and brain injury, psychosis, and other cognitive stuff. And then what questions, like what do you prefer? Do you prefer sativa? Do you prefer indigo, hybrid? If they say they, want indigo, I always think, well, indigo helps with sleep, and it helps them cool down and sleep. So then I'll choose my medications appropriately according to that. And usually, that'll be on the next slide after this. Usually I look at like Remeron, mirtazapine for that. That'll help with sleep. And then one of the things I'll say, hey, one of the side effects is that you might have, the munchies. And they'll start giggling because they're like, oh yeah, I'll have the munchies anyways. Oh, it's perfect. So I kind of have to buy them into the medication a little bit. But then I'll say, well, but it's meant to treat for depression, anxiety, and they'll give it a try. How much money do you spend a week? I say, because I want to know if how much they're actually using. And because sometimes they don't know, because I'll ask, well, how many grams? Well, I don't know, just that much. But if they tell me how much money they're using, I kind of get more of an indication of actually how serious this problem is. What's the longest you've not used for? Because if you ask them about sobriety, they're like, oh, I don't know. I don't know what that means. But I kind of want to know if they've actually tried not using and what challenges they had when they did try to actually stop. Was it family challenges or something else? Have you lost your friends because of your drug use? Remember? So this is related to if they lose friends, that's the best chance I got with them to get them to stop. What does your family, boy, girlfriend think about you using drugs? Okay, if there's a lot of opposition there, that's going to help. What's your drug of choice? That's what I mean by DOC. Sometimes marijuana isn't their drug of choice. It might be something else, but most of the times for the kids I see, it's usually marijuana. What else have you experienced with? And the myth is it's not a gateway drug. It is a gateway drug. It does. So hopefully I proved to you that they're chasing the first high, the receptors are downloading, they're trying to treat themselves, and eventually they need something else. And that something else is something else. If they use alcohol and marijuana, the risk of aggression and impulse goes out the roof. Like it actually goes higher. So then you're dealing with someone that's probably a little bit more aggressive. And what do you think it helps with? So again, get from them, why do they think they're treating themselves? And so this is part of your dessert as well, I thought. So SSRIs are kind of used for depression, first-line depression, right? Lexapro, Prozac, use those for kids. Wellbutrin, I've used that. That kind of targets that kind of the middle center that helps with the addiction response as well too. And Remeron is kind of what I told you as well too. Some of the other things I've tried gabapentin. It's kind of a mood stabilizer, but it also helps with the cravings as well too. And when I dose these kids, I don't heavy dose. I just want them to try it. But if they're a serious user and they've used a lot, I don't want to dose them too lightly because then they're going to say it's not going to work and it didn't work and I don't want to try it. So I really got to really determine how much and who's going to get what. And there's no set pattern. I don't go to one medication all the time. It really depends on the kid in front of me. Naltrexone, this one they use for the opioids, alcohol addictions, right? Use this for a few of my kids, not many. A lot of the kids that have actually got themselves into a lot further down the addiction, and they need a lot more help. I can probably count on just the years on my hand on how many kids I've treated with naltrexone. It's a great medication. The antipsychotics, I've used that as well too. So most important, you want to treat the withdrawal, you want to treat the ADHD. So ADHD kids actually have higher substance abuse issues as well if you don't treat the ADHD. You want to treat the bipolar, right? They also have higher substance abuse issues as well too. You want to treat the anxiety, the PTSD, and the depression. So what I want to do is I want to treat all that before I start treating the substance abuse. And I'm going to see what's left behind. So if there's still anxiety left behind, then I'll start treating the anxiety. But the anxiety, you can't get it down to zero. You're not supposed to get that down to zero. Everyone's supposed to have a little bit of anxiety. I'm sure we came up with some bit of anxiety because that anxiety is supposed to motivate you. The only time you have zero anxiety is probably when you're dead. Okay, so never try chasing that anxiety down to zero. Listen, don't judge, just ask. So, my stepson, he was addicted to marijuana at an early age, like before I came into his life. And it just, I saw it get worse to psychosis, to jail time. He's an adult now and getting treated for like mood stabilization, and he's living someplace else now. But I think as a parent, it's hard sometimes not to judge and get really mad at them. But remember, if you're dealing with an addiction, you need to really be mad at the addiction and don't take it on that kid. And just don't judge and just try to figure out what they need and help them. Motivational interviewing. You guys heard of this before. This is tough too. Like what it means is you got to meet these kids where they're at. If some of them are not ready to quit, and it breaks my heart, but I have to like let them be and just provide them with the resources, and the case managers help them with the outpatient appointments and hope that they do at some point quit. Okay, just 2 more slides left. Okay, so basically the ACAP has said that they didn't agree with kids using marijuana. ACAP is the American Association of Child Adolescent Psychiatry. They also found that if they legalize marijuana, you're going to make it more accessible to kids, and they found that harmful, and that's what we've seen as well too. So here are some numbers. I'm sure you guys have got all the numbers, and I think I have a minute left. Do you guys need questions and answers, or no? Okay, I got a question.
So the sense of that slide that you had about kind of the different effects on the CB receptors for the THC, and then I also noticed on there were some notes about CBD and how it doesn't really bind to that receptor. And so I was just wondering if you had any information or insight as to how does it work? What is the they say is the big, the marketing is about that it influences the cannabinoid system, but from what I was seeing in your slides, it doesn't look like it really fully binds to those receptors. Am I right?
So you're talking about the CBD oil? Yeah, so I could go back, but I think it says it's like an antagonist. So what that means is it doesn't bind to the slide, but actually turns it off. So rather than turning it on, so you don't have much of that reward system as more of a calming and everything kind of turning off. I'd probably have to look into that a little bit more. If you give me your email, I can get back to you. You do that? Yeah, okay. Any other questions at all? No? Okay, thank you so much for your time. I appreciate it.